Hi, friends. Welcome to another episode of the Clinical Trial Podcast. I'm your host, Kunal Sampath. If you want to build a long term career in clinical research, there's one skill that sits at the center of everything it's clinical trial design. Because at the end of the day, the quality of your research and the decisions that come from it depend on how well the clinical trial or the clinical study was designed in the first place. In this episode, we're focusing on a part of research that doesn't always get enough attention: observational studies. When should you use them? When are they more appropriate than randomized control trials, RCTs? And how do you actually design them in a way that leads to meaningful, trustworthy results? To break this down, I invited Dr. Thomas Newman on the podcast. Dr. Newman is a professor of epidemiology and biostatistics at University of California, San Francisco, and co-author of a widely respected book, Designing Clinical Research. His work has shaped how researchers think about study design, bias, confounding, and interpretation of results. In this conversation, we cover a practical framework for designing observational studies, when observational studies are the right choice over randomized control trials, RCTs, the biggest pitfalls, bias, confounding, and misinterpretation, and how to think more clearly about causality in clinical research. If you've ever struggled to understand study design or felt intimidated by statistical concepts, this episode will help you build that foundation. Please join me in welcoming Dr. Thomas Newman to the Clinical Trial Podcast.
Great clinical research professionals aren't born, they're built. In each episode, hear from leading experts in clinical trial management as they inspire and motivate you to become an effective leader. Welcome to the Clinical Trial Podcast. Here to help you accelerate your career is your host, Kunal Sampath.
All right, Professor Newman, thank you so much for taking the time to join me today on the Clinical Trial Podcast. It's really an honor and a privilege for you to be with us here today. And I'm just personally excited. I've known of you and I've briefly talked to you for the last few years because I recommended one of the textbooks that you've written, Designing Clinical Research, the fifth edition to the students that I work with at San Jose State. So thank you for all the work you've done. And it's really, it's rare to find amazing people like you that have made such deep contributions to the clinical research industry. So thank you so much.
Well, thanks for inviting me.
One of my goals for the podcast is to inspire clinicians, by that I mean medical doctors, to learn about clinical research and to pursue this career in addition to their clinical responsibilities. You have years of experience in education designing clinical trials, medicine, and clinical epidemiology. So as a clinician, when and how did you get involved in putting together clinical trial designs?
I haven't done much in the way of clinical trials, actually. A lot of clinical research, but most of it has been observational studies.
I see.
A lot of it using electronic medical records from Northern California, Kaiser Permanente.
I see. So let's kind of delineate for people the difference between clinical trials and clinical research. Maybe I want to hear your definition of that.
Well, I would say clinical trials are a subset of clinical research.
Mm-hmm.
In which the treatment is assigned by the investigator.
Right.
So they're called experimental studies, and those are distinguished from observational studies where investigators don't assign the treatment. They just compare, if they're looking at the effects of a treatment, they compare people who were treated to people who were not treated, but they're not the ones who decided who got treated. The treating clinicians or the patients themselves are the ones who decided that. So those observational studies, of course, are a lot more challenging because what you want to estimate is the causal effect of a treatment, but that can be confounded by all other differences between those who got treated and those who didn't that might lead to differences in outcome.
Right. So just maybe we can take two steps back with like your career and your journey. So you have your bachelor's in chemistry, and then you got your MD from California, University of California, Davis, and then you
No,
had your
San Diego.
in San Diego, sorry. And then, University of California, San Francisco, you got your residency in pediatrics, and then your MPH from Berkeley, and then your postdoc fellow from University of California, San Francisco. Did you always how did you envision your career to go? Did you just end up how did you end up getting started with research? Because I'm assuming at some point you wanted to be just like a medical doctor, but then you somehow pivoted or decided that I want to do more than just being a doctor.
Well, I think consistently, I wanted to be involved with teaching and in training people. Initially in pediatrics, my initial faculty appointment was primarily in pediatrics. I've always liked epidemiology. I was good at it in med school, and the clinical epidemiology fellowship I did really just cemented that. I really enjoyed it and was good at it. And, I think initially sort of two reasons for doing research. One is that the faculty appointment I had required that I do research if I want to get promoted. And I was okay with that because, I had some ideas for research and was interested in both answering specific questions, having to do with taking care of babies and older children, and also interested in research methods. So one of the first studies that I participated in was didn't have anything to do with pediatrics, but I had learned some about epidemiology at Berkeley, and had a conversation with a friend who was at the CDC and was supposed to study Agent Orange. And I had this idea of using the draft lottery as a way of studying delayed impacts of military service during the Vietnam era. And that, turns out to have been a great example of what is now called an instrumental variable analysis. And, it was sort of a new way of looking at, again, it was, in a way, it was sort of a natural experiment. So kind of partway between an observational study and a clinical trial.
Right.
Certainly, I didn't assign the treatment, but it was assigned randomly based on birth dates. And in this case, the treatment was eligibility for the Vietnam era draft as opposed to actual military service.
I see. But what does that have to do with the orange agent? Is that related or not?
Well, that was how I got the idea. As it turned out, Agent Orange stopped being used before the draft lottery happened, so we couldn't use it to study that.
I see.
But it still seemed like an interesting way to study delayed effects of military service. And we found that people who had lower draft lottery numbers and were therefore more likely to get drafted had higher rates of death from suicide and motor vehicle accidents in the 10 years after they would have come home.
I see. What do you think? Like you've mentored and taught so many students over the years. What do you think is the biggest challenge, especially for medical doctors to get started in this doing clinical research? Your point about yes, you get promoted if you are publishing papers and doing research, but where do people get stalled? I'm curious, and how do they overcome those barriers?
Well, I think my first recommendation is to get additional training in how to do research. We have a training program at UCSF called Training in Clinical Research that can be a 1-year certificate or a master's program. And I would highly recommend that for people who want to do research. And a challenge for that is, can you do that? And especially, can you find someone else to pay for it? Right. It's great if you can, get a fellowship where the people who run the fellowship view clinical research as important and recognize that you'll do it much better if you get adequate training, and they have money that can help support fellows to get additional training in clinical research. If you have enough money, you can pay for it out of pocket, but it's expensive. So just getting additional training in clinical research, I would say, is the first challenge. And second major challenge, second step, or maybe even the first, even before that, is finding one or more mentors who can help you. People who are maybe 10 years or more older, who have positions like what you would like to have, or have done work like what you would like to do. And they can help you, again, find maybe opportunities to get the additional training. And they can especially help with what I think is the next big challenge, which is finding research questions that are, this is like in the book, right? Novel and feasible, right?
Right.
Questions that you can actually maybe answer within, a few years, and time to get some publications for promotion. Or even if it's not required, you want to be able to, start something and finish it and get an answer that you can share with the world. And there's so many projects that get started that never get finished. So having a good mentor who can help you identify good research questions and feasible ones to answer. Like you said, the finer criteria.
Yeah, the finer criteria, exactly. Feasible. I'm trying to remember what the I stands for. Want to help people out. If do you happen
to think?
Yeah, it's been a minute since I have the book right in front of me, so I don't mind.
I know novel, ethical, and relevant are the NER.
Yeah,
interesting. I think is
interesting.
The I.
Yeah, interesting.
Yeah.
So you're saying people like start the projects and then they never finish, in terms of like they never get their results published, I'm assuming, or they never...
that happens a lot. Yeah.
I see.
Yeah, because it turns out to take, most of the time, research takes longer than you think it's going to. It's more challenging, and people have conflicting priorities. So having a mentor, who can encourage you and tell you, the idea is that the mentor will help make sure that before you even start on it, that it's worth doing, because there's going to be bumps in the road and things that are discouraging, and you may think, I don't have time for this, or it's not worth it, it's too much trouble. And if you have a mentor who's actually been with you from the beginning and thinks that this was a question that's worth answering in spite of the fact that it's going to be difficult, then it helps encourage you to continue even when you've hit some discouraging spots.
Right, absolutely. So I think, coming up with interesting research question, like working with a mentor, I agree. Like, I think there's a leap between like getting the results done and then people like lose steam, and then they don't know how to like get it published, or like doing a poster presentation at a conference. One of the ways I actually started my career also doing pediatric research at Boston Medical Center in the NICU. I partnered with a physician there. And we did a retrospective analysis of the data on the neonates in the NICU there. And then obviously he was my mentor, and he kind of helped me along the way, and he knew all the steps, and the fact that we had to get IRB approval, which is the Institutional Review Board, and then, collecting the data, analyzing the data, and then applying to a Congress to go and present it. And it wasn't like a fancy Congress. It was like, I think, a small regional meeting that was happening in Rhode Island. And Newport, Rhode Island, and we just drove up there and presented our paper or our poster. So it can be really pretty straightforward, but I think having some guidance around that would be very helpful. And I do tell people, like, you definitely want to get your work published. And I think that's a lot where people get stalled. So when it comes to observational studies, like if you were like designing an observational study, or were giving advice to somebody who wants to plan an observational study, where should they start? I was in this same role in December 2023. I was trying to start an observational study. I had done plenty of like randomized control studies and so on, but I never like started an observational study from scratch, and I kind of felt stuck. I didn't know where to go next. So one of the resources that I found was this book by, or not the book, but the Registries for Evaluating Patient Outcomes, a User Guide by AHRQ. I kind of printed that myself, and then I kind of used this to learn. And there were a lot of similarities with clinical trials when I was reading this. But yeah, I just wanted to, obviously I had a very slow start because of my knowledge gap here. So I wanted to see what should people do to start a registry or an observational study.
Well, again, the first step is to have a good research question. A lot of the trainees that we work with are practicing clinicians, are MDs, most of them fellows or maybe junior faculty. And one thing I like them to do is think about, okay, so there's some question that you are going to spend a bunch of your life trying to answer. How do you know whether it's interesting, relevant, feasible, and so on? And I say it is really helpful if you can actually think of a patient that you saw where there was uncertainty about what to do. And if you had the results of your study, you would have been able to make a better decision about how to diagnose or treat that patient. And so the idea would be, and I mean, if that's probably the best place to get ideas, is that you were taking care of a patient, you looked in UpToDate or you looked at the literature, there was stuff that wasn't there that you wanted to know, or there's conflicting advice or something. So you start out with a research question where the data that you collect would be helpful to allow you to better diagnose or manage a patient. For the observational studies, I think I would divide those into a couple of groups. I mean, there's some observational studies that are aimed at trying to figure out what caused someone to get sick. So, like case control studies are typically, you're trying to figure out risk factors for disease, things that people might have been exposed to that might have caused them to get sick with the disease that they got. And there's another whole group of studies that are just descriptive, just how frequently does something happen, for example, right. Adverse effects of a certain drug. So you're going to study a bunch of people taking a drug and quantify adverse effects. And these are some of the studies that electronic medical records make more feasible.
Absolutely.
Where it's a rare adverse effect, but there isn't really a question of whether the drug caused it or not. It's something that just doesn't happen unless you're taking the drug,
Right.
So or would be way less common. And again, if you have, because you can have a much larger sample size and a reasonable cost, you can look for these rare adverse effects. The more challenging kind of observational study is when you're trying to estimate causal effects of a treatment. So that is when you're sort of trying to use an observational study instead of doing a clinical trial. And the big advantage is that it's, way less expensive, way more feasible. And the big challenge is that people are not treated at random. So in designing such a study, the probably the best way to design it is to think about, if you could do a randomized trial, how would you do it? What would be the inclusion and exclusion criteria that would allow you to select the group of patients in whom you want to estimate the causal effect of this treatment or exposure. And then, again, using observational data, try to find a group of patients who were treated. And you could be comparing, it's probably easiest, most straightforward, if you can compare two different treatments. But these studies are especially challenging when, you could say, okay, the treated group, I can identify them. They're the group that got treated with this particular medicine for a certain indication.
Right.
But it's one of the challenges, one of the things that this is called designing a target trial can help with is trying to say precisely when the follow-up time begins, not just for the treated group, but for the untreated group. For the treated group, it's easy. You can say, follow-up time started when they got their first dose of the medicine.
Right.
But if they could have gotten the medicine at 2 or 3 previous visits and they didn't, then it's a lot more challenging to figure out when does the follow-up time start for the people who didn't get treated.
Right.
And that's why it helps a lot if there's some event that can lead to a treatment. For example, somebody has their first seizure. Okay, so we know what time the seizure happened. We know what day, they went to the emergency room and so on. And maybe some people got started on medicine A and some people got started on medicine B. And maybe that is actually kind of random. I mean, maybe that just depends on what emergency room they went to or what doctor they saw.
Yeah.
And then it's easier to, do a comparative study comparing treatment A to treatment B. But you can also compare, a treatment to no treatment when you have that nice clear starting time, which is that they had a seizure.
I see.
So they had a seizure and some people got treated and some people didn't. And then you can look, follow forward in their medical record and see how many had, a second seizure or an additional seizure among those who were treated, among those who weren't.
Right. Okay. So talking about like basic framework for an observational study, you kind of touched on it, but maybe can you give like a high level overview of how to like just put like think like how to use what's that framework look like?
Well, again, there's so many different types of questions with observational studies. If we stick with observational studies that are trying to estimate the causal effect of a treatment, which I think would be those that your clinical trial podcast audience would be most interested in, I'd say, there are some treatments that start and end in a very short time, like a surgical treatment, where you do the treatment and then follow, people afterwards, but it's nice and short. And there are other ones that can be more challenging, where it's a treatment that you start a certain medicine and you are on it chronically for months or years.
Right.
And those studies are a bit more challenging because you have to think about what do you do with the people who start a medicine and then stop it.
Right.
Right. And if you were doing a randomized trial, you would say, okay, I'm going to compare people who I have equipoise, right? I don't know whether this treatment is going to be beneficial or not. I have some indication that that would be like one of my inclusion criteria for my randomized trial if I were doing a trial, but it becomes an inclusion criterion for the observational study. And I say, okay, now I'm going to look at people who got that treatment. If I were doing a clinical trial, I would randomize, say, you're going to get the drug, you're going to get placebo. And let's suppose that some of the people who got the drug, 2 weeks later decide that it makes them sick and they stop it.
Right.
When we analyze that randomized trial, we have to still analyze them in the group to which they were originally assigned.
Yeah,
right?
The intent to treat population.
Exaction, intention to treat. One of the mistakes that people make when they do observational studies that are trying to emulate a randomized trial is they use information that was not available at the time the treatment decision was made to decide whom to include. So an example of that would be, okay, I'm going to study people who, got started on an anticonvulsant after a seizure and were on it for at least 3 months. Well, you can't do that, right? Because if you were doing a randomized trial,
You wouldn't
you
know that.
randomize people to start the treatment, right? And all the ones who have some bad side effect or something that, excuse me, something that leads them to stop the treatment. Again, in a randomized trial, you would still have to analyze them according to the group to which they were originally assigned. So, an observational study, what we call those, we compare initiators, that is, people who start a treatment, to non-initiators, people who didn't start a treatment at the time when they had the same indications.
Right.
And then
What are Mhm.
even if they stop the treatment, they still have to be analyzed according to the fact that they initiated the treatment.
Right. Right. What are some of the statistical challenges when it comes to observational studies, like when you're actually doing the analysis?
So I would say that's the biggest one. The most straightforward ones are the ones where you have this treatment and it happens. Like I've done a bunch of studies of phototherapy in newborns for jaundice.
Yep. I think my son was in
And
that clinical trial where they put him on a bed with like lights and stuff. Yeah.
yeah.
Mhm.
So, was actually interested in late adverse effects of phototherapy. So the phototherapy was just, a very short time for a few days.
Right.
And, we looked, following up to 20 years afterwards.
Oh,
Um,
wow.
so, but even phototherapy, when we studied the effect of phototherapy and how good it was at lowering bilirubin levels, our treated group got phototherapy within 8 hours of having a bilirubin high enough that some people would start phototherapy.
I see.
And the control group didn't get phototherapy within 8 hours.
Right.
Um, some people in the untreated group might have gotten phototherapy later, but again, we analyzed it according to did they get it within 8 hours or not.
Right.
So I think one of the biggest challenges is, especially for treatments that don't happen, that aren't a point treatment, something that happens quickly, is how to deal with people who stop the treatment and then they may start it again. And how do you deal with the non-initiators who, in a randomized trial, they would have been assigned to the control group. They didn't initiate the treatment, within some period of time after having the indication, but then they go and initiate it later, right?
Yeah.
And again, if you do an intention to treat analysis, which is the proper way to do it, the problem is that you'll have a result that's biased towards the null,
Right.
because some of the people that you wanted that started on the treatment didn't keep taking it, and some
Right.
of the people who didn't start on the treatment started on it later.
Right.
And the challenging statistical approach to that often involves what's called inverse probability weighting,
Mm.
where you make up for the fact that the people who started a treatment and didn't continue it might be different from the ones who started it and continued it. And the people who didn't start it initially but started it later might be different. And at least theoretically, if you have all of the factors that are associated with outcome that also are associated with these decisions to start treatment late or to stop it or restart it, you can control for those statistically. But if all you have is an electronic medical record, it may be that you don't have all the data that you would need in order to be able to control for that statistically. And the statistical analyses to do that, the inverse probability weighting, are challenging.
Right. Right. So we briefly touched on like the RCTs are like the gold standard. Uh, so when and why are like observational studies a better choice?
Well, I already mentioned that they're way cheaper and
Cheaper.
quicker often,
Hmm.
especially if you're doing like a retrospective cohort study. Um,
Yeah.
they often also will include a much broader range of the population of interest. Um,
Yeah.
this comes up especially, in clinical trials sponsored by the pharmaceutical industries. They want everything to be nice and clean, and so they'll exclude a lot of people that have like other comorbidities. Even though out in the real world, once the drug is approved, that may be a majority of the people get treated. Similarly, they may exclude, old people, people over 65 or 70 or 75,
Yeah.
even though, again, many patients in that age group get treated. When you're doing an observational study, you can include, many of these patients that would have been excluded from clinical trials and get an answer that is relevant to the patients in whom the treatment may actually be prescribed.
I see. I got it. Okay. Um, so I think the observational studies for like, um, I guess products that are already FDA approved or cleared are going to look a bit different than observational studies for products that are not FDA
Yeah,
cleared.
although, as you know, um, once the drug is approved for one indication, it can be used for other indications.
Off
And
label.
so an observational study might be done to see whether this drug, which is already approved, might work for some new indication. And those studies are great because it costs so much to get a drug, through the approval process.
Yeah.
Um, if you can find drugs that are already on the market, and especially if they've already, been shown to be safe for some
Yeah.
other indication,
Yeah.
and then you can find that they work for something different, those
Yeah.
studies are great.
Yeah. I think with those studies, I think it isn't it harder to get the indication expansion approved by the FDA, like the expanded indication,
Yeah,
just based on the
although
results of the observational study. Go ahead.
um, I think you probably know more about the regulatory process than I do, but my understanding is that you need to get approval for an indication if you want to market it for that. But if you show that it works, people can still use it, even if the
Yeah.
drug
You just can't
company
promote it.
can't market it for that indication. It can still be, yeah. I guess
Correct.
it's off-label use. You can still, and in
Yeah.
pediatrics, the majority of our treatment is off-label because most
That's
of
true.
drugs haven't been studied in randomized trials in kids.
Yeah. Is this primarily
So,
because
and that's
the
that's a
economics don't work out?
yeah. Unlike people my age and older, most kids are healthy. And almost all diseases are just much more rare in childhood than the adult diseases. The heart
Right.
disease and the lung disease and the Alzheimer's and the kidney diseases and diabetes and stuff that older people get, much less common in children. And so it's any kind of randomized trial in children usually will have to be a multi-center study with many, many centers, and those
Yeah.
are expensive to do.
Absolutely. Yeah.
And
Also, the
then, of
regulatory
course, the
requirements
market is
are
going to be smaller,
correct. Correct.
right? The when you're looking at, okay, how much is it worth to do the studies to get an indication for this drug? You're looking at what's the potential market, and if it's a pediatric market, there's not going to be that many kids that have it. Especially, I deal with newborns. If it's a newborn market, they're not going to need very many milligrams
Right.
of your drug because they're little babies.
Yeah.
And so
Absolutely.
those things all make it less appealing to the pharmaceutical industry to do the studies necessary to get a approved indication.
Yeah. Absolutely. Um, yeah, I think with the indication expansion, I do find it a bit challenging using observational studies to get the regulatory approvals in place. For the expansion. There is definitely a way. I just think it's a little nuanced. The goal of many studies is to estimate causal effects. That's something that the book talks about. The association observed in a population may differ from a causal effect for the four reasons: chance, bias, effect, cause, and confounding. Can you take can you give us like a quick overview of what these terms mean and why do they matter? And maybe it doesn't have to be quick, but at least I think just to orient people on what are these four terms, like chance, bias, effect, cause, and confounding.
Yeah.
And yeah.
And just because we're talking about causal effects, you said
Causal
casual a
effects.
couple of
Wait,
times. Yeah,
causal,
causal
causal.
effects.
Sorry,
So,
causal. That's because I typed it wrong, and it's clearly that's what I'm reading. Yeah.
okay. So let's start with the easiest one, which is chance. So if you do a study, and you figure that the probability of the outcome is, one probability in the group that got the drug and a different probability in the group that got placebo, um, you're dealing with probabilities and you can have bad luck, just as, you could flip five heads in a row if you're flipping
Mm-hmm.
a coin,
Mm-hmm.
even though maybe the probability of bad outcome is lower in the treatment group or than in the placebo group, or it would be with a very, very large study,
Mm-hmm.
especially if your study is small. You're not able to say as much, you're not able to estimate the effect of the treatment as precisely. So, and the way we quantify the effect of chance is really with confidence intervals. So if you have a small study, your confidence interval will be wide, meaning a wide range of possible effect sizes would be consistent with the results that you got. And the bigger your study, and especially the more outcomes you have, the narrower the confidence interval can be. And if the confidence interval excludes the null effect, the more confident you could be that this did not occur by chance and it's an actual real effect.
Absolutely.
So that's chance. So, and the short answer about chance is confidence intervals are the way to quantify the possible effect of chance. Then the next one is bias, and with chance, basically the idea is that the bigger your sample size, the less likely you are to make an error due to bad luck or due to chance. That's different from bias because no matter how big you make your study, if there's a bias in how you're measuring your variables or uh, looking at your follow-up time or something like that, um, you'll still get the wrong answer. So bias is a systematic difference between the answer your study would get with a very large sample size and the true result, the true answer that you're trying to get. And it could be because of measurement error. It could be because your measurements are not blinded, right? That's a kind of measurement error, but that's what can cause a bias. Um, it could be because you made mistakes in how you allocated the follow-up time or something like that. Um, so bias is what you're trying to prevent when you design the study. You want to get an unbiased estimate. And then effect cause, well, that's, if you see an association and you think it's because A caused B, you need to make sure that it isn't that B caused A, because that will cause those two to be associated as well. And that comes up mainly in cross-sectional studies where the measurement of predictor variable and outcome variable are done at the same time, because the main way to rule out effect cause is to show that the cause preceded the effect. But, if you're studying, it's especially true, I think, if you're studying, prevalent exposures, people who are exposed to something,
Yeah.
uh, you want to, make sure that they didn't, start taking that drug because they had some symptom of the disease or something like that.
Right. Okay. And then the last one was confounding. It'd be great to also go a little deeper on the confounding with
Confounding is 90% of that chapter really is probably about confounding.
Confounding, yeah. Mm-hmm.
So, and confounding, I can't really draw a picture here, but the basic idea of confounding is that there's a common cause of the exposure and the outcome, meaning something causes people to be exposed and also causes the outcome. And the classic example of that is you could, if you did a study, you could probably find that people who carry around matches or a cigarette lighter are more likely to die of lung cancer. Well, it's not because carrying a cigarette lighter causes you to get lung cancer. It's because people who smoke are more likely to carry a cigarette lighter or matches, and they're more likely to get lung cancer. So smoking is the common cause of the exposure, in this case, carrying a lighter, and the outcome. And that is, and trying to figure out, when you're doing an experiment or a clinical trial, you can eliminate confounding as an explanation by randomizing the two groups. So we know that at baseline they were equivalent, especially if there's a large study. But in the real world, when we're comparing people who got treated to people who didn't, or people who got treatment A to people who got treatment B, we have to worry that the people who got treatment A were different than the ones who got treatment B. And that could be one big family of confounding in studies of treatments is called confounding by indication. And what we mean by that is that the reason you got treated was because you were at higher risk of the outcome. Makes sense, right? Who are the people you most want to treat? The people who are at highest risk.
Yep.
And if you don't control for confounding by indication, then treatments will look worse than they really are.
Right.
This is in most cases. It's certainly in pediatrics. I'll give you an exception in a minute. But for example, if we look at, in the studies that we did looking at phototherapy to prevent a high bilirubin level, if you don't control for confounding, babies who got phototherapy are more likely to have a high bilirubin level than babies who don't get phototherapy. In the whole population, look at all live births, babies who get phototherapy more likely to have a high bilirubin level. But of course, the reason why they got phototherapy is they had a high bilirubin level, already, and and it was going up, and people were worried that it would go up higher, and that's why they got the treatment.
Right.
So when you control for that, then you see that the babies who got phototherapy were less likely to have to develop a dangerously high bilirubin level. The exception, so I'm used to confounding by indication, making treatments look worse than they really are if you don't control for it adequately. And then when you control for it, the treatment, actually, you can see that there's a benefit. My colleague, I heard a lecture by Vinay Prasad, who's an oncologist. And in his mind, confounded by indication is just the opposite. So he worries about confounding by indication and making drugs look better than they really are, or falsely good. And that's because he's an oncologist, and a lot of the treatments given in oncology have a lot of toxicity. And patients don't get them if they're frail or sick or their prognosis is bad. The people who, people are willing to try some new potentially toxic medicine on are the ones who might have a better prognosis or might be, in better shape in other ways, less likely to have comorbidities and so on.
Right.
So if the people that you treat are those who are healthier as opposed to sicker. And again, that you could consider that an indication for this drug is that they were healthy enough to be able to tolerate it. Then the drug can look falsely good rather than falsely bad. So it's just important to think about, who is getting the treatment? How might they differ from the people who don't get the treatment? Can we measure things and then control for them statistically that might allow us to compare comparable groups in terms of their prognosis? So we could compare people who would have had similar outcomes had they been treated the same way.
Got it. Okay. I know the book also talks about like stratification, multivariable modeling, and propensity scores. Can we briefly touch on those as well?
Yeah, those are all different ways to try to control for confounding. The simplest is stratification.
Yep.
If we were going to study the effect of carrying matches on lung cancer, well, we could control for smoking by seeing whether there was any effect in non-smokers, and then separately whether there was any effect in smokers. And you might say, yeah, but maybe the people who carry matches are more likely to be the heavy smokers. So instead of just stratifying by smokers versus non-smokers, we could stratify by non-smokers, light smokers, medium smokers, heavy smokers, and then look for the association only within those groups to make sure that we weren't getting a false association that was due to smoking.
I see.
So that would be stratification. In the book, one of the examples we use is eating red meat as a risk factor for colon cancer. And it turns out that males have a higher risk of colon cancer and eat more red meat than females. So you would want to stratify by sex if you were looking at the association between eating red meat and colon cancers, so that you wouldn't have part of the effect that you might observe be due to the fact that the males eat more red meat and are at higher risk.
Yeah.
So that's stratification. That's easy. Multivariable analysis is, trouble with stratification is that you can only do it for one or a few variables at a time. And then you start, again, if you're looking within strata, your sample size is getting smaller and smaller within those strata. And if you have a lot of different predictors of outcome that might also be associated with the treatment or with exposure, then you need a multivariable technique to adjust for multiple possible confounders simultaneously.
Right.
And another thing that multivariable, there's something called the Cox model or the proportional hazards model. That can also take into account if the follow-up time is unequal between the groups.
I see. So that's called the Cox model when the follow-up is different, right, between the groups.
Yeah. And there's still big assumptions involved, right? That, if the reason why the follow-up time is shorter in one group is because, something bad happened to them that you don't have a measurement of, then the Cox model is not going to fix that. But just, again, going back to our studies of phototherapy, during the years that we were studying at Kaiser, phototherapy became much more common. It was used more and more. And we were looking at outcomes like cancer. And so the amount of follow-up time, the more follow-up or seizures, either of those, the longer someone is followed, the more likely they are to have a diagnosis that we're looking for. So we use the Cox model to make sure that we didn't miss, because the follow-up time was shorter among the babies who got phototherapy because it happened more often later in the study. So we use the Cox model to make sure that we didn't miss an effect that otherwise might be hidden by the fact that the follow-up time was shorter in the group who got phototherapy.
Got it. Okay. And the last one was the propensity scores.
Yeah, so that's a multivariable technique that has become more popular lately.
Yep.
And there are certain advantages. So propensity scores, what we're talking about is the propensity to be treated. Okay. So what we do is we look at the people, we create a multivariable model, usually logistic regression, and it's a model to estimate the probability that a particular person would be treated. And then each person in the study, again, they have to meet inclusion criteria so that there's some chance that they would be treated. Some people would treat them and some people wouldn't. Um, and then we create a model to estimate each person's probability of being treated. Okay, and let's suppose we're treating someone with say steroids for asthma or something like that. Well, not everybody with asthma gets steroids, and maybe the people who get steroids, talking about systemic steroids, have worse asthma than the people who don't get systemic steroids. But can we create a model to say, here's how I'm going to predict whether this person would get steroids? And we'd have various measurements of how severe the asthma was and maybe what medicines they were already on. And now we're going to assign each person a probability. So they either got steroids or they didn't. But we're going to create a model to say, here's what their probability of getting steroids was. And for some people, it might be 20%. Some people, it might be 40%. Some people, it might be 80%. If it's close to zero or close to 100%, we can't study those people, right? We can only study people who, some people would have treated them, or they could have gotten it, or they could have not gotten it. And now we have this probability or this propensity to be treated that we calculated based on all our other variables that we have on all our subjects in the study. And now we have a new variable, some number between 0 and 1, their propensity to be treated. And now what we're going to do is compare people who were treated to people who were untreated, but only with similar propensity scores. So I'm going to take, say, everybody who had between a 20 and 25% probability of getting steroids. So most of them didn't, but some of them did. And I'm going to compare among people who have a 20 or 25% probability of getting steroids, those who got steroids to those who didn't. And I'm going to do that again for, 25 to 30%, or I could match for each person who got treated. I'll find someone who didn't get treated but had the same propensity score. And that way, that's another way of controlling for confounding that has some advantages.
Great. Thank you so much for explaining that. So for folks that you guys are not following or have more questions, I highly recommend checking out the book. If you're watching this on video, that's the book. I'll put it in the show notes. It's called Designing Clinical Research, 5th edition, by Professor Thomas Newman and Professor Browner, and among many other folks that have contributed. So I highly recommend you take a look. Professor Newman, I think just for people to I think, yes, the UCSF course is a great one. The book is a great resource. What are other ways for them to I think a lot of people that there's different camps of people in clinical research. There's people that are very good at operations. There's people that are great at statistics. There are people that are great at science. But I think there's a basic level of understanding we all need. I think that also the appreciation for some of the concepts that we've been talking along. What are some strategies to, other than the book and the course, is there any other resources that you recommend that they can find useful to understanding their to improve their understanding of the statistical concepts and so on?
I think some of the stuff is hard, and probably the only way to really understand it is to work through problems. Realistic problems, I think are good. So our book has problems, has problem sets, with the answers in the book.
I love it.
Um, there's online courses, that you can take where some of them are even free, where you can pay extra money to like get a certificate or something. But I think the key is, for a lot of these things, you can hear a lecture and you can say, that kind of makes sense, and then the next day most of it's gone. So some learning opportunity that allows you to work problems and then find out whether you got the right answer, and then if you got it wrong, figure out why, and then do it again, I
I
think is
see.
the best way to learn it.
I got
Doing
it.
it in a group can be really helpful because it's more fun and you can make friends and you can encourage each other. And even better than working problems, the best way to learn this stuff is to explain it to other people.
Yep.
So if you have an opportunity to work with other people together and do problems together and explain your answers to each other, I think that's the way that it's most likely to stick.
Yeah. I love it. Thank you. I think those are some solid advice. Do you any online courses that come to the top of your mind right now that you want to bring up? I know there was one that I did on Coursera by Bar. Trying to remember, it was on statistics. Yeah, I'm blanking out on the name right now, but I'm sure I could pull it up. I think it was by Barbara was the name of the lady that
Uh-huh.
taught it. But yeah, if there's any that you recommend, or
Um, all of our courses are online, and a lot of the stuff is free to the world. I think generally the homework assignments, I think for a lot of them, the recorded videos you have to like pay money for,
yeah,
but the PowerPoints slides for those videos I think are free to everybody, and the homework assignments. So that's one resource just that I'm very familiar with.
yeah,
Um, if you want to do observational studies to estimate causal effects, it's really helpful to understand something that we call DAGs, or directed acyclic graphs. This is all the rage now because people are wanting to do these so-called target trials with machine learning. Um, but there's a free course on DAGs by Miguel Hernan at Harvard, which is really excellent. I liked it so much I actually paid the money to have access to the course materials afterwards.
oh,
So
nice.
anything by Miguel Hernan is likely to be excellent, and he has a great course on DAGs.
Okay, so you said the UCSF course with this, and then if you people want to like the slides
Yeah,
up
people
across,
just
yeah,
yeah, people just Google the UCSF Training and Clinical Research Program.
yeah,
You'll see all the courses. Um, a lot of the materials are free to the world on the web.
yeah, and then the Miguel the DAGS program at Harvard. Was there anything else you mentioned? I'm just trying to take notes as we're talking.
Um, None that come to my mind, but I'm sure there are excellent courses online, and I guess I would say the biggest challenge is forcing yourself to actually like commit. I mean, one of the big reasons to take a course, and maybe even to pay money for it, is that then you feel committed to doing the work and doing the problems. Because
Right.
all this stuff, it takes a significant investment of time and mental effort, and
Yeah.
you're probably not going to understand it well if you just passively try to just passively read a book and passively listen to a lecture.
Right. Right. Yeah, I agree. I think the book that the designing clinical research, I like all the exercises in the back of the book, back of every chapter. I think those are like great. And I think your advice about like doing it with a teammate or like another person or more than a person, like in a group setting, is solid. Yeah, the course I was talking about was by University of Cape Town, understanding clinical research behind the statistics. I thought that was like a cool course that they had online, and that was also yeah, free. Perfect. A couple more questions. I think you kind of started talking about machine learning, and I wanted to see like where do you see like the observational studies head with the advent of AI, and how is that shaping our world, and what are some underutilized opportunities that are right in front of us that people should be exploring and consider when they're planning observational studies.
Um, Again, well, I think you know, electronic. So a couple things: electronic medical records. Um, you know, raise the possibility of being able to do studies that were not as feasible before. The other thing is there are a whole lot of carefully collected data out there that people are sharing now. There's much more sharing of data and many more publicly available data sets. And that may be low hanging fruit, particularly if you're in an area that, like I am in pediatrics, or an area where you're seeing things that are not like the most common diseases, but um, uh, where there just haven't been as many investigators studying questions in that group or the questions you're interested in.
Right.
Um, I do think there's a potential danger with electronic medical records or even existing data sets. So the great thing about them is you may be able to get a great answer to your question with little expense and it'll be valid. The danger is that you may be tempted to try to answer your question with a data set that just isn't up to the task. And you may, I mean, I've seen this before, again, with our trainees or with papers I've reviewed that, for journals that have been submitted, where in order to answer the question, you have to make certain assumptions. And in some cases, those assumptions just aren't reasonable. And that doesn't stop people from, writing up these papers and trying to do these studies, because they need to get a project done in order to finish their degree or their fellowship, and this is the data set they have. And if they don't make these assumptions, they can't get an answer, so they make them, but it just may not be reasonable.
Right.
So I just think that's important. This is again where a mentor can help, if it's a good mentor, to have you not spend a bunch of effort trying to analyze data with a data set that doesn't have all the information that you need
Yeah.
to get a valid answer.
Yeah. Yeah, so the data set that they're working off might be limited, is what you're saying. But
Yeah,
yeah,
yeah.
I agree. Yeah. Hmm.
I mean, an example of that is there's a data set that's just an inpatient data set for pediatric.
Hmm.
The children's hospitals have gathered together. They have an inpatient data set,
Yeah.
and but if you want to study something like asthma, right, where someone gets admitted with asthma, what treatments they got, as an outpatient or in the pediatrician's office before they came into the hospital, is key information, and it just isn't in that data set. Right.
Yep.
So
Makes
that
sense.
would
Yeah.
be an example.
Yeah.
Or
It's like these.
even,
Mhm.
again, many of these data sets, if you want to know causality, in many cases, it's really important to know exactly when someone got a treatment.
Yeah.
And it may be that the data set only has the calendar day that they got it
Yeah.
and not the actual date and time that they got it. And then you may not be able to tell whether they got that treatment because of something that happened
Or something
or
else.
it caused something that happened later, because you don't
Right.
know exactly when they got it.
Yep. One of the thoughts I had as we were talking about the research question and then coming up with the inclusion exclusion criteria, what are your thoughts about like using AI to like come up with those criteria? Because I feel like any clinician or even a group of clinicians by themselves might not, like a couple of doctors, like I just, even if they're thought leaders, I feel like they're always missing something when it comes to inclusion exclusion, which leads to like protocol amendments down the road. And I'm trying to get your thoughts on like using AI to like really fine tune those criteria. Have you seen applications of that, or what are your thoughts?
I I am a big fan of AI. The one I happen to use is ChatGPT. I find it extremely helpful. You just have to remember that it hallucinates, right?
Yes.
So if it doesn't know the answer, it'll make something up, and it'll make it up and it'll seem really plausible. But as you pointed out, if there's, you know, um, if you're thinking about inclusion exclusion criteria, it may come up with something that you hadn't thought of before. And then once you see it, you go, oh, wow, I should have
Yeah.
thought of that. Right. And I'm not worried that it's hallucination. I know it is something that I should have thought of, and I just didn't think of it.
Correct.
And that would be a great use of AI.
Yeah. Perfect. Yeah. Thank you for validating that in that way, because I did feel like there's a huge missed opportunity here. And a lot of companies, I know, obviously academic institutions as well, they subscribe to these AI tools like ChatGPT, but their version of it. And then you could use that because it's if it's proprietary information, you don't want to use the free version, for example, because, if your employer doesn't want you to train the language learning model. But yeah, I think that's great. So thanks for sharing. Also, like, you talk about like getting, like, are you working on a project maybe where you're getting data from Kaiser? Do you like have access to the EMR and then you like submit to the IRB to then do retrospective research? How are you using that? I'm curious.
So I've been very lucky that I was able to cultivate and maintain a relationship with the Division of Research at Kaiser. There's, it's, for what I was interested, it was great source of data. I think, the goal should always be to develop collaborative relationships with someone who has access to the data. I think at Kaiser, they're very justifiably protective of the data, and what they don't really want, and what they won't just let anyone come in and say, hey, I have a great idea, can I use your data to answer this question? But so the key is to find a question that someone there, one of their clinicians or investigators, is also very interested in answering, and then work together, making sure that they get adequate credit and publications and grant funding opportunities and so on, so that again, it's a collaboration rather than a more just taking advantage of them.
Right. Yeah, that's great. Thank you for sharing that. I think those were all my questions. Are there any other resources or tools or advice do you have for people before we wrap up our conversation today?
I think I've given. Well, there's our other book. Yes, I want to for sure plug.
Yes,
So
please.
evidence-based diagnosis,
Yes.
second edition, Cambridge University Press. It's not just about diagnosis. It's about it's a clinical epidemiology. It's called an introduction to clinical epidemiology.
Yeah.
It's a great resource for people who are taking care of patients and making clinical decisions. And it has a lot of problems, and the problems are sort of all our best. We've been teaching this for more than 20 years. The best problems from over the years, and almost all of them are based on real studies, real clinical situations.
Yeah.
I've sort of been of the opinion that if you can't find real examples that illustrate the stuff that you want to teach and why it's important, then maybe you shouldn't be teaching it. So our book is full of, often it's examples of where published literature makes some mistake that we want to teach people not to make.
Right.
So I recommend that.
That's great. Thank you for sharing. And that I'll put that in the show notes for people. I'll link it up and people can check it out. I'll also link the Design and Clinical Research book as well. Like I said, it's an amazing textbook and just a resource for anybody that's working in clinical research. Doesn't matter whether you're in operations or designing research questions as a scientist. I think it's a valuable resource for one and all.
Yeah, and
And
we get
also,
almost no royalties from either one. I donate all of them, but nowadays libraries, buy these and allow people to download them. So I know anyone in the University of California system can download both of our books for free.
that's
And I
great.
don't know about that may be true in the state college system as well.
There is probably true, but I do appreciate you sharing that. But yeah. So if you can afford it, purchase the book. It's available. I'll see if I can get a discount code from the publisher. I have been able to do that in the past, but I'm not sure if I can do that for the podcast. But I will try. Yeah, and it's pretty inexpensive for the learning you get, and I'll also link to your website, Professor Newman, for people that want to just get to know you more and like the work that you've done. So I'll put that also in the show notes.
Okay, great.
Yeah. Thank you so much for your time today. I really appreciate it.
You're quite welcome.
Professor Newman, one last question about books that have influenced the way you think and they have had an impact on your life. Would you like to share any with the audience today?
Oh, well, I'd have to say that the clinical epidemiology book by Sackett et al. That was first published in the 80s had a big influence. So, but it's, our book sort of took over for that one. So when we first started teaching our course, it was based on that book. And then we added enough new stuff that we wrote our own. No, I just, in the email that I got, it was just sort of what I'd been reading lately or what I recommended. And so I thought about that. And I just want to give a plug for Michael Lewis. I love his books.
Yes.
All of them. And also anything by Naomi Klein. Her recent book, Doppelganger, I really thought was very insightful. And books by Rachel Maddow I recommend as well. And Barbara Kingsolver. I just read Demon Copperhead and enjoyed that.
That's great. What was it, Rachel? What was her last name?
Maddow from MSNBC.
Okay. Okay, perfect. Which book did you read with her?
Well, she wrote one called Prequel, which is sort of about how popular the Nazis were, right? Before World War II in the U.S.
I got it.
And
yeah, I see that.
Really scary. Yeah.
Yeah, and
she also wrote a great book called Blowout.
Got it. Okay. And then you said Michael Lewis. Is there a favorite that you have with Michael Lewis?
I like all of them.
Okay.
The last one, The Fifth Element, I thought. It's just nice because he, in his last couple of books, has highlighted what some civil servants do. Some people that nobody ever thinks about them. And this is, I think, a very relevant time for that book.
Absolutely. Like, who is the government? Is that the one you're talking about? Yeah.
Well, there's,
the Untold Story of Public Service.
Yeah, that's the most recent one. That's actually by a bunch of authors.
I see.
But the one I think he did before that called The Fifth Element? Or something like that.
Element. I'm trying to. The Fifth Risk.
The Fifth Risk, yeah. Fifth Element is that movie with Bruce Willis. The Fifth Risk, yeah. It's excellent.
Okay, that's good to know. Yeah, I think I read one of his books, The Flash Boys. I think about the stock market.
Fun. That was great. Yeah.
Yeah. I do remember reading that.
Some of them have been made into movies.
Yeah, and what was the other? What was it?
Doppelganger is the Naomi Klein book.
Okay, great. I'm going to put that in my, add that for people to check it out. And then the last one was Barbara. What's her last name?
Kingsolver.
Okay, great. Is there a book with her that you found?
I've read a bunch of them, but her most recent book, I think, is Demon Copperhead.
Okay, got it. Okay, perfect. Thank you so much for all these amazing resources for people to check out and keep them busy and off their screens and in reading some interesting material that's going to um, increase their I think just get the most out of life. I would say maybe that's a better way to put it. So
Good.
thank you so much. Yeah,
You're quite welcome.
Thank you for listening to the Clinical Trial Podcast. For more exclusive clinical research content to get you to the top of your game, head on over to clinicaltrialpodcast.com.